Today we will see bloodless surgery and medicine. So before knowing about the bloodless medicine, we need to know something about the transfusion medicine, its evolution and its history. So the first thing was the Pope Innocent VIII. He's in 1492. It is said in literature that he drank human blood to save himself from death. Nobody knows what happened to him. And then later, William Harvey, he is a British physician. He came up with the idea of human circulation, how the arteries and the veins function. That was in 1628. And then Richard Lower, he started transfusion between dog to dog, and it was successful. The point to be noted is he is a British physician. Then a French physician came in 1667, Jean-Baptiste Denis. He also tried to do the same thing between lamb to human, but it was forbidden. Like he was stopped to doing that between animals to humans because it was not probably working. And then in 1795, Philip Physick, he is a American physician. He started, he did the first human transfusion, but he failed. Then, this point in red, please note down, we are all proud to be obstetrician because of this thing. The first successful blood transfusion was to a case of PPH in London, and the donor was the patient's husband. And later on, the blood transfusion continued until he published an article, Human Life Being Saved by Transfusion. So many a physician were consulting this obstetrician to learn more about the transfusion. One such person is Samuel Armstrong Lane. He is a American physician. He got some idea from this obstetrician James Blundell, and he started using the whole blood to treat hemophilia. In 1900, then only they introduced the ABO blood group. Carl Linster he introduced. So the point to be noted here is obstetricians used blood transfusion even before the blood group was identified. Okay, so then Ludwig Houghton, he said cross matching has to be done to prevent mismatch and the reactions. And then later on in 1912 only they identified O as a universal donor and AB as a universal recipient. Then in 1914 they identified that sodium citrate prevents clotting and refrigeration is a method to store the blood, Richard Lewison. And in 1932 the first blood bank was started in Leningrad, Russia. And in 1939 RH system was introduced. In 1940, Edwin Kohn, he separated plasma into albumin, alpha globulin and fibrinogen. Then later and then they used sodium citrate glucose as a cryoprotectant, and they tried to use centrifugation as a method to separate the placenta. In 1950, there came the plastic storage. So previously they used to store the blood in the bottle containers, and then the plastic storage came. And later on in 1958, they identified the HLA antigen on the cell surface. And in 1960, plasmapheresis was identified, and this helped to remove the cells for the patients who are undergoing chemotherapy and cancer patients. In 1970, they started screening for hepatitis B. And one year that is a very challenge in the transfusion history is 1980s, with the identification of the human immunodeficiency virus and the transfusion, how they were trying to diagnose it, how they tried to prevent it. All these were challenges in transfusion. And in 2000, FDA licensed for the use of nucleic acid amplification test to screen HCV and HIV. In 2014, FDA approved pathogen inactivation system, especially for the war-prone areas, the military zones. So now coming back to our topic, bloodless surgery. So who are all going to get benefited by this bloodless surgery? We have a group of people called the Jehovah Witness. They follow some kind of messages written in Bible. For them, it is forbidden to eat meat or the flesh that has some soul, they don't drink or touch the blood of another soul. So they are the people of Jehovah Witness. They probably get benefited by this bloodless surgery, or the patients who refuse blood transfusion. So why do we need a bloodless surgery? First thing, it is more prone for infection. Bacterial infection, HIV, hepatitis B is possible. Is the chance of acquiring infection is there. Second thing is transfusion related immune modulation or transfusion induced immune modulation is something that activates the latent viruses in the body. They become infected, and second thing, there is activation of cancer cells there, so they getting neoplasia. There are many theories to support transfusion induced immune modulation. Third thing is the allergic reaction, fever, chills, myalgia, all those things. And there is last one is mistransfusion. There are, because it is a process, uh, mistransfusion. We might there may be errors in cross matching, collection, storage. Anything is possible. So, what is the risk of transmission of infection? So, HIV is 1 in 1.5 million donations, HCV 1 in 1.2 million, whereas hepatitis B is only 1 in 2,90,000 donations. So, we have to be very careful with this. And the bacterial contamination is 1 in 100,000. So, how are we going to provide a bloodless surgery or medicine to the patient? So, it can be grouped into preoperative, intraoperative, and postoperative. So, preoperative, we have to prepare the patient. We have to prevent anemia, make the patient fit for surgery. Any causes for anemia has to be diagnosed and ruled, treated properly. And you can give some drugs, GnRH analogs. Tranexamic acid can be used to stop bleeding temporarily. If the bleeding is because of some AUP, some uh, like some estrogen progesterone imbalance, then we can give OC pills. So if the patient is taking some over-the-counter drugs like NSAIDs, aspirins, or some Chinese herbal drugs, we have to stop them. And one drug that is erythropoietin. Erythropoietin is playing a very beautiful role in bloodless surgery because it is produced normally in the kidneys and liver. It helps to increase the um, RBC mass, and it helps to increase the oxygen carrying capacity. It is available in 3 different brand names: Epogen, Procrit, and Anisp. It is in the chromosome 7q21. Intraoperatively, how we can reduce the blood loss. So the first thing is we can avoid GA because GA causes more blood loss when compared with the local anesthesia. Second is the normovolemic hemodilution. It is like we pass it through this open circuit. Patient's blood is going to the circuit and then coming back to the patient itself. That is normovolemic hemodilution. Third is the hypervolemic hemodilution. That is, we use ringer lactates, crystalloids, and colloids. By increasing the volume, we are giving hemodilution. And deliberate hypotension, so the blood does not have to pass through or squeeze through a high pressure system to get lost. So we give deliberate hypotension. Deliberate hypothermia, when there is hypothermia, the oxygen need for the cells is decreased, so oxygen carrying capacity is not much needed, so that is good. And intraoperative cell saver is a chamber which collects the blood that is lost in the surgery, and the same cells will be utilized or put back into the patient's circulation. Intraoperative cell saver. And last thing is deliberate hemostasis, like using harmonic scalpels and ligages that prevent blood loss. Last thing is postoperatively. Postoperatively, we can give blood substitutes like perfluorocarbons. These are the particles that are smaller than the size of the RBCs that can pass through the circulation arterioles, capillaries. And these molecules are easy to produce, cheap to produce, and they can be mixed with any blood group and they can be infused into the patient. These are perfluorocarbons, but the disadvantages, they cause some flu-like symptoms, so it was withdrawn. FDA prohibited its use. And the other thing is your HBOC, that is otherwise called as hemoglobin based oxygen carriers. They are some molecules that are prepared with alpha beta dimers, and with the addition of some pyridoxal 5 phosphate that has less affinity to oxygen, so that oxygen will be released to the circulation. So these are the artificial blood or the blood substitutes. So these they all should have some 10 criteria, ideal points. So it should be easily produced, cheap to produce, readily available, and the oxygen carrying capacity should be compatible or comparable to the biological hemoglobin, and it should function as a volume expander. There should not be any need for cross matching. It should be pathogen free. It should have minimal side effect, and it should be stable in a wide range of temperature. It should have a long shelf life, and it should be cost effective. So these are all the constitute criteria. No substitute come close to the criteria except for these perfluorocarbons and hemoglobin based oxygen carriers, and they are all produced by artificial reproductive technology, recombinant technology. Of this, the perfluorocarbon is prohibited by FDA.